Hello, my name is Martine. I'm a pediatric nurse practitioner. I work in the heart center at a children's hospital. Pretty busy program here in New York. And my project is looking at integrating a negative pressure wound therapy. It's called the Prevena into our current wound management process for post-op pediatric cardiac patients. This is just a picture of a hypoplastic left heart syndrome baby who is undergoing a Norwood procedure. It's the most complicated congenital heart surgery that we do in the country, in the world. Carries the highest mortality and is performed within the first week of life. Patients who undergo this procedure are typically in the hospital for about a month to recover. That's if they survive the procedure. Typically after this open heart procedure, many times the sternum is left open for a few days, for about a week, to allow the baby to hemodynamics to stabilize, for some of the edema to downtrend. And so the patient may have an open sternum for about a week, and so those kids are very critical. They may not be fed and are prone to a lot of wound breakdown and high risk for sternal wound infection. And they therefore are a big part of why I wanted to work on this QI project. At the end of this session presentation, the participants should be able to identify and explain some of the rationale as to why we're integrating the Prevena into the wound care protocol for these high-risk infants, identify key stakeholders involved in the implementation, gain some understanding of how I will use Carter's 8-step change model to implement this project, and assess the potential financial impact from implementation. Why is this important? So the proposed change is to address the need to improve our current wound care protocol and integrating the Prevena into the post-op wound care. So annually, this hospital performs between 200 to 300 cases of open heart procedure. And right now, our current practice is to close the incision primarily, apply Dermabond, skin glue, and then cover that with a Npwt, which is a silicone dressing. This dressing is changed daily until the patient is discharged. For our high-risk infants whom we have delayed sternal closure, the incision is closed at the timing of delayed sternal closure with interrupted sutures to enhance, the interrupted sutures enhance the wound's tensile strength. So we have two surgeons here at the Children's Hospital. We'll say the chief surgeon, Surgeon A, is the head of the program, introduced the Prevena after seeing it being used at another children's hospital. He is a strong advocate for incorporating it into the post-op wound care. So he's a champion for this initiative. The other reason why this is important, the current wound care protocol is expiring. So this is an optimal time to introduce and incorporate the Prevena. We have the Prevena here um, at the hospital, but it's available. It's on the shelf. It is rarely used appropriately or for the indications for which the literature recommends it to be used. And we use it haphazardly. And it's usually an afterthought. When there is wound breakdown, when there are signs of ongoing infection. And so I wanted to just streamline how we do our post-op wound care. And so why the Prevena? So the Prevena is a type of wound vac, and it's specifically made for closed incision. It's new and innovative. It has been reviewed and studied extensively in the adult literature. There are some pediatric literature and indication. And so it is a vacuum assisted closure that goes on top of a closed incision, and it maintains the incision dry, and it's vacuum, and so it suction all exudates and debris into the device. It's proven to enhance circulation and promote oxygen delivery to the incision because there's a consistent vacuum of about 125 millimeter of mercury pressure. It's been proven to decrease lateral tension of sutures because it approximates the skin edges and wound suture edges, and it provides a protective barrier against environmental contamination. So for, let's say, our complicated patients who have open sternum, so these kids are intubated for a prolonged period of time, many times what you will find is that the ET tube and its components are sitting on top of the sternal incision, and so this provides a more protective barrier against environmental contamination. Also, we talked about this. Existing research strongly indicates that the Prevena reduces the incidence of surgical site infection. And it's best if applied immediately post-op to minimize the risk of infection and wound breakdown. There is some limited direct evidence in pediatrics, but enough to prove its indication here. And the fundamental wound management principles associated with the Prevena are all applicable in pediatrics. The Prevena prevents a very favorable benefit to risk ratio. And so to hone in the importance of incorporating this into our wound care protocol, drawing on extensive literature, there is enough compelling evidence to support the implementation of guidelines here for our wound care practices. The literature reinforces the importance of having guidelines because the guidelines will show a more, will help with delivering a more deliberate practice, and it's evidence-based practice. It will enhance a more precise delivery of what we do, and it will elevate our overall quality of care. Incorporating the Prevena. So, like I said before, currently our use of the Prevena is very limited. It's usually an afterthought. We have post-op cardiacs who are low risk, and those patients are typically in the hospital for 2 to 3 days, and so the risk of developing infection and breakdown is extremely low. And then we have our complex patients. In pediatric CT surgery, all diagnoses and procedures fall under STAT category, and these STAT categories are based on complexity. And so the higher complexity patients are the patients who have prolonged cardiopulmonary bypass, inflammation, systemic inflammatory response syndrome, so edema. They have prolonged intubation, increased risk for sepsis. They are unlikely to be fed for days because they are too tenuous or unstable. They may be on too many pressors to initiate feeds, and those patients have the highest risk of developing the wound infection. And so the indication for the Prevena is specifically tied to those patients. So my objective here is to seamlessly integrate the Prevena into our current wound care protocol, because right now when we use the Prevena, it's often retrospective versus proactively, and that type of practice lacks an evidence-based rationale, and it deviates for the Prevena's intended use. There's been many studies looking at the Prevena. So what we know about surgical site infections for those patients who are high risk, those STAT categories, STAT category 3, 4, and 5, is that they can carry a morbidity mortality as high as 30%. So those are like your hypoplastic left heart syndrome babies who have undergone Norwood, single ventricles, truncus, and I'll talk a little bit about those patients later on. Those patients who are at high risk for developing a deep sternal wound infection may require up to 6 weeks of antibiotics because once identified, we treat for 6 weeks to prevent endocarditis. And so babies don't go home with PICC lines for antibiotic therapy. They stay in the hospital. So that's 6 weeks of hospital stay. Where in an adult, that may be the practice. What population will we serve? So our high-risk neonates, we know who they are. Well-identified babies, so your STAT category 3, 4, and 5. Patients with delayed sternal closures tend to be those STAT categories. Patients who are who develop an infection and are now going back for debridement and reclosure. And we have a lot of our babies who go in the OR in a catabolic state. Those are high-risk babies. They're low birth rate. They've been in PO because they have a heart disease condition and are on pressors and cannot be fed because we're worried about them developing neck. They go into the OR in a catabolic state. Babies who are strictly on TPN. TPN is not a natural feed therapy, and those kids tend to actually have poor wound healing than our healthier and low-risk babies. We will apply the wound care protocol for all children who are undergoing cardiac surgery, and so from birth to 18. what providers are involved in this project. So I had to get buy-in from a lot of people. Big team here. We have our congenital surgeons, we have our OR nurses, and nurse leaders, nurse managers, the PICU, because the patients, my goal is to have this apply in the OR under sterile conditions, and the patient is transported to the PICU and have this continue in the PICU. When Prevena changes in the protocol will be every 5 to 7 days, and so having to change the Prevena in the PICU, I needed buy-in from the PICU nurses, nurse managers, our all of cardiology nurse practitioners, administrators, nurse educators to help with future training and sustainability, and then our wound care specialists. A lot of our babies may continue their hospital stay in the NICU if they have some feeding difficulties, and so the NICU staff as well. And so my goal, my aim is to achieve greater than 60% compliance with the wound care protocol. And my focus is to incorporate the Prevena into our wound care policy. I am measuring adherence in utilizing the wound care protocol, and this is a newish one that will incorporate the Prevena for this specific target patient population. So our low-risk infant will have the usual skin dressing, Dermabond with a MEPI on top, and then our high-risk patients, which will be listed in the protocol who those are, will be fitted with the Prevena in the OR. So patients are getting primary sternal closure, or at the time of their sternal closure if they have delayed sternal closure. The Prevena includes, I put a picture there for all to see, there's a foam purple sponge, there is a Tagaderm film that covers the purple sponge, there's suction tubing, there's a collection canister, and then either an electric or battery operated vacuum pump. Our preference is to use the electric pump. I like it because there's less errors than this vacuum pump that comes with the kit. And the continuous setting for the Prevena is 125 millimeter of mercury pressure. The nurses will document like they would for low risk, high risk, any patient post-op, any drainage, quality, quantity of the fluid, or any concerns. And we're going to change the dressing every 5 to 7 days under sterile technique for the Prevena. How implementation of this new protocol integrating the Prevena will require training for the nurses because there are many incidents of leak from the Prevena if anyone's used a wound vac before. So if just a patient who's fluid overloaded, they are third spaced. As they start to improve and they start to diarrhea, sometimes they have leakage around the incision. A lot of it comes through the skin because it's an open site, and so it may interrupt the integrity of the Tagaderm. And so there may be a lot of leakage and the dressing not sticking so much to the skin. And if this is happening in the middle of the night, the nurses need to know how to troubleshoot the machine and the wound care. So there, my plan is to do the training 4 times a week, have day shift and night shift groups. The session will last an hour, and it will be in the conference room of the PICU. Again, the overall overarching goal is sustainability, and I would want to expand and extend the application of this wound care protocol to other departments for their wound management routine. And so the goal is to have continuous education for the nursing, highlighting just the critical role that they play in this project. So I will involve the education department, have had some meetings with them as well. And the model that I will use for implementing the project is the Carter's 8-step change model. John Carter is a professor at Harvard School of Business. I don't know if he's still there actually, and introduced this 8-step change process in his 1995 book. And it is a process for how to effectively manage a change initiative with focus on transforming organizations to meet this change. Again, what my SMART aim is to get 60% compliance and adherence of nursing to the protocol over a 3-month period. So I will be spearheading the change effort, developing a sense of urgency around the need to have a more consistent process that includes the Prevena. Carter suggests having, in order to have a successful change, you need 75% of management to buy into the change. Identifying the true leaders in your organization, and so managers of the PICU, the OR, the supply management team, the surgeons. So identifying the leaders as well as all stakeholders, asking for an emotional commitment from these key people, and then work on building teams within this My Change Coalition. Developing the vision. You know, what are the values that are central to the change? What is, how am I going to craft and disseminate the protocol? And then enabling action to educational initiative and training will be a key component of what I do. Collecting and analyzing the data we will do with PDSA cycles, achieving early victories, and we'll have just some short-term goals and long-term goals. Consolidating the gains, anchoring the change. Once we have some wins, analyzing what went right, what needs improving, and moving the goalposts, setting goals, continuing to build on some of the momentum that we've achieved. Anchoring change is a long-term goal. Having this be embedded in our practice and into the children's hospital culture is very important for sustainability. And so how to gain that sustainability for here, definitely through education, and nurses are the most consistent people at the bedside, and so they are an important part of this project. Cost benefit analysis I've looked at. So the standard dressing for Mepilex, and this is for a box of 65, I believe, is approximately 125. The Prevena is a little bit more expensive in that an individual unit is about $495. The subsequent dressings are a little bit cheaper. The system comes with what I've listed before, and it includes the battery operated machine, but subsequent dressings are cheaper versus a 7-day hospital stay at the Children's Hospital. And this is at a minimum is 130. This is a 7-day hospital that required an OR for wound infection and debridement. For the concern for mediastinitis is approximately $137,000. So definitely cost-effective process to do, as the Prevena has been shown to minimize the risk of surgical site infection. And we know, I included in one of the slides, previous slides, that surgical site infection is listed as a hospital-acquired infection, and it will not be paid by CMS if it occurs, and so it behooves the hospital to minimize its occurrence. There are multiple subcommittees in the hospital to address this issue, and so let's see. Oh, okay. I'm not sure where my reference. So this is a very important project to me. I'm excited, and so are the surgical teams and the PICU NICU teams. Thank you for your time.